Thank you. I'd like to start by thanking the organizers of the conference. It's always helpful to bring together people with shared experiences and expertise and overlapping goals. I think good ideas and good new directions can emerge from that kind of conference. I'm not going to go through telling you what I'm going to tell you. I'm just going to tell you. So let's start with a question. What do all of us, not just doctors, but everyone in this room and probably every person in this country wish we had more of every day? What do we all need to achieve our goals, personal and professional? Or another way to frame it is, what is the currency of the 21st century? So when I ask this question in a smaller group, more conducive to a dialogue, people offer ideas like, well, maybe it's information or knowledge, maybe it's health, money, gold, the obvious ones, security, maybe we all need that. Really, and I think the answer to this question was foreshadowed by everything that came before in this conference today. Really, it's my belief, and I hope you agree, but if not, we can debate it over wine later. The currency of the 21st century for all of us is time. Time in our time. Let me just give you an example from work. So I work for a healthcare agency, as Rich said. We're right upstairs. People under 30 or under 35 even, when they need my attention, they instant message me. People over 35 use email. So I think there's a gradual shift in the patience that people have based in part on the impact of technology, making us want feedback, information faster, quicker, better. This is Jacob Nielsen. Those of you who've been involved in information technology probably have heard the name or recognize him. Early in the internet era, Jacob Nielsen published a number of studies and books, and he said people will wait on average 10 seconds, or they will search for 10 seconds to find what they're looking for before they start getting stressed. They'll wait for information to download about 1 second. He published that about 15 years ago, and I would venture to guess that patience and attention spans have gotten shorter since then. So let's talk a little bit about HCP marketing in the digital world today. Let me give you a full disclosure. I practiced emergency medicine for 10 years. I don't practice anymore. For the past 15 years, I've been the chief medical officer of a pharmaceutical marketing company, two of them really, Razorfish Health and Digitas Health, are both in this building. So I have a happily schizoid existence. Part of my job is to think like a clinician on behalf of our clients. And part of my job is to think like a marketer and try to figure out how we can persuade or inform or even just get doctors to pay attention to what our clients would like them to pay attention to. So well, those of you in pharmaceutical marketing, I assume that's a lot of people in the room, remember it wasn't that long ago where it was very easy to put your brand name all over the office. Practically, you could put a Post-it and stick it on the doctor's forehead with your brand name. The rules were lax, and there are probably 10 billion pens with brands' names on them floating around the country. And then the government started paying for more and more and more of healthcare and started imposing more and more rules. Life got harder. But still, when you think about what pharmaceutical companies do and biotech and device manufacturers do, all the different tactics, really the unifying feature is this. What we're trying to do is leave an impression on the physician, literally or neurologically, maybe not literally, right in their hippocampus. We want to forge long-term memories, right? And we want to get right into their frontal lobe so that when they're making executive clinical decisions, our brand, our product, the benefits of our product come to mind. That used to be easier to do than it is today. I get 400 emails a day, about 150 of them are spam, but about 100 of them are messages like this for conferences about how are we going to reach healthcare professionals with our messages? What are we going to do now that the rules keep changing and making the life of a pharmaceutical marketer more and more and more difficult? So anyway, here's what I do for a living. There are 5 physicians at Digitas Health. We're 5 among 400 bright, young, mostly young, creative types and marketers and analysts and media experts. And what we do is, in brainstorming sessions, when we're trying to come up with tactics or programs or resources or tools to earn a physician's attention, the role of the physicians in our company is to ask, that sounds great, that would be cool, that would be neat to play with, that would be fun to look at, but why would a doctor really be interested in it? Would it be relevant to their clinical needs? Would it solve a problem? And so on. It's very easy to come up with cool ideas. The technology has advanced to the point where anyone who's smart and understands programming can come up with a good game. The challenge is to get and earn doctors' attention. You better crawl into their headset and figure out what they lose sleep over, what they care about, what they love about their work, what they hate about their work. So let's jump to EHRs. We all know, and this is just a partial list, there are many, many, many positive features to the digitization of medical record keeping and communications. And there are also a lot of negatives. Those of you who work for EHR companies probably know this better than I. You deal with doctors, you get their feedback. I presume you adapt your systems to address their concerns and their issues. If there's a common feature that resides underneath all these bullet points, it is, once again, I would submit, time. Do EHRs make life easier for doctors? Do they help them? Let me pull a Mark Rubio here. Do they help them get their job done better, faster, underline faster, more efficiently? I did an informal survey of 10 doctors on our advisory board. And again, this is not statistically significant. It's not a comprehensive survey. All 10, when I said the EHRs, the EHR you use, does it make it easier or harder to do your job? They all said harder. I said, do you get your work done in less time or more time? They all said more time. But I'm confident, not just based on what I've heard here today, but what I've learned through reading and what I know about EHRs, that, as many of the speakers already said, we're at a point in time where we're really just at the tip of the iceberg, as somebody said. These systems will improve, they will get faster, they will get more usable. Again, what's the problem? Well, they're not super easy to use. They're not like an iPhone. And that's among one of the many issues that clinicians have with EHRs. So let me backtrack a second and talk about what doctors know. Again, my goal is to put those of you who are not physicians for the next 15 minutes in the shoes of a physician with the hope or the intent that it will help shape or jar your thinking about programs or tools that might be helpful to doctors in the EHR context. So not just doctors, how does anyone know what they know about healthcare and medicine? Well, there's a pathway. There's research, both basic research and clinical research. If the outcome is meaningful, the research is generally published, not always in the New England Journal, but somewhere. Journal articles are aggregated and summarized. That's what ends up in textbooks and guidelines. Those materials are the basis of medical education, which doesn't end after 4 years of med school, but is lifelong. And that's what informs what your doctor, your internist, your family physician, your pediatrician does, hopefully, when he or she is figuring out what's wrong with you and prescribing treatment. Med school, I'll go through this quickly. You probably all know this. Med school is an arduous process. Here's the Dartmouth curriculum from a few years ago. After high school, the average doctor goes through 11 to 16 years of additional training. Malcolm Gladwell, great journalist, great writer, wrote a book 5 years ago called Outliers, in which he proposed that if you do something in an intensive way for 10,000 hours or more, that was the guesstimate, it changes your brain not just quantitatively in terms of all your new neuron connections, synapses, it changes how you think qualitatively. And I think that's true of physicians. I know from personal experience that was something I think I lived through during my medical training. So for example, you'll look at this. Some of you might see the woman in the upper left and think she over-tweezed her eyebrows. A doctor might look at it and think, oh, she has hypothyroidism. The picture of the fingernail, you might think that person hit their finger with a hammer. A doctor would look at it and wonder whether that person has vegetations growing on the valves of their heart that are embolizing and ending up in the distal small blood vessels. That right upper cardiogram, a doctor would look at and think this person is at high risk of a stroke, they better get on blood thinners. The lower cardiogram, the doctor looks at and doesn't just see a squiggle, he sees someone who's going to be dead in 5 minutes if they don't get a shock. The space between the two front teeth, You might look at it, if you're not a doctor, and think this person needs orthodonture. A doctor would look at it and wonder whether that person's mother had syphilis when the child was in utero, because there's something called Hutchinson's teeth. The face doesn't fuse normally if the mother has syphilis. And last but not least, this is not a person with cankles. This is a doctor would look at those legs and think, probably has right-sided heart failure and is accumulating fluid on that basis. So on and so on and so on. That is part of how doctors think. They learn, just like anyone in any other specialized field, they learn to see the world differently. Now, there was a time, and this photo is from Hopkins, I think about 110 years ago. There was a time when just having that large fund of clinical knowledge, bedside ability to diagnose based on signs and symptoms and history, was enough to be considered a great doctor. That is not the case anymore. I think we all know that. That's part of the reason why EHRs are important, or maybe part of the reason why EHRs can help improve the quality of medicine. There's a concept called evidence-based medicine. I think it was the term, I think, started in the 90s. Don't hold me to that. And the principle of evidence-based medicine is that the doctor applies his or her expertise, also factors in what the patient wants, the outcome wants to get out of the clinical encounter, and layers in the best available research to decide what tests to order or what treatment to recommend. Jerome Groopman, another great writer, published this book a few years ago. He's an oncologist in Boston. He had a problem with his hand. He went to 5 hand surgeons. He's a doctor. He was misdiagnosed by all 5 hand surgeons. And he wrote this interesting book which analyzed the thought processes of these surgeons to try to figure out why not only no one could figure out what the problem was, but why they were so sure they were right, even though in retrospect they were wrong. And it's a fascinating book. If you're the kind of person who gets paranoid when they go to the doctor, then I would not read it. But otherwise, I would recommend it. But the truth is, and there are all sorts of biases that I don't have time to go through them that doctors make, just like comparable in some ways to the misjudgments that everyone makes in everyday life. But the truth is, even if doctors were computers, even if they had perfect judgment, there's too much information being published every day for even the sub-specialist to stay up to date. And not only are doctors fallible individuals, but the healthcare system in this country, I think in most countries, has gotten so mind-bogglingly complex that the system itself has errors built into it. When you have that many exchanges of information, that many handoffs, that much data, errors happen. And famously, or I should say infamously, the Institute of Medicine issued a report 14 years ago estimating that there were 100,000 accidental medical errors in the US every year. A few years later, they published another report with recommendations on how to fix that problem, crossing the quality chasm. But it seems to me, and I'm going to guess that it probably seems to many people in this room, that EHRs, an optimized system that leverages the best of what electronic technology and computer technology has to offer, present at the point of care, has the potential to really make evidence-based medicine a reality. Right now, it's just an aspiration. So let me give you an example. In the last article I saw, and I wish somebody would repeat this research, this was in the Archives of Internal Medicine 15 years ago. Either they followed or they interviewed family physicians, and they found that on average, in a single day, there were 16 clinically important questions that affected patient care that the doctors did not know the answer to. I would guess that if there was a machine existed that could tap into the physician's subconscious, you would have found 116 or 1,016 questions. But anyway, the point is, even the smartest doctor doesn't know the best course of action in every clinical scenario for every patient. So what does it come down to? There are known knowns in terms of questions that arise. That is a question that pops into the doctor's mind that he or she knows the answer to right away. There are unknown knowns, questions that pop up that the doctor is pretty sure exist somewhere in a prescribing information or in the medical literature, or his colleague down the hall might know the answer. So all he has to do is apply some due diligence and we'll get access to it. And then there's this huge, huge third category of unknowns where the doctor doesn't even know if anyone knows the answer. That data might not have ever been aggregated. The problem might never have been studied. The answer might not exist. So let me give you an example to make this concrete. So let's say a doctor, an internist, has a woman come in with severe hypercholesterolemia, and getting back to those physical exam cues, he doesn't even have to get a lab test. He looks at her face and he sees these cholesterol deposits, which are known as xanthelasma, a sign of severe hypercholesterolemia. Let's say it's a woman who's dropped out of care or escaped clinical care in the era of statins and is not being managed for her hypercholesterolemia. So what's the known? So the doctor might say, okay, right off the bat, I want to start her on a cholesterol-lowering drug. Thanks to the successful marketing efforts of AstraZeneca, most doctors in the country will know instantly that Crestor is the most potent, rosuvastatin, most potent cholesterol-lowering drug. There's the unknown knowns. Let's say he finds out this patient has some renal insufficiency and he's not sure if the cholesterol starting dose has to be adjusted or not, but he can go to the prescribing information, or in the era of PDR briefs you just heard about, he might be able to get that information quickly through his EHR. And then, and this is what I was talking about 2 minutes ago, there are the thousands of potentially unknown unknowns. It's like, okay, I'm going to prescribe Crestor, I'm going to be confident that it's the best drug for her, but do I really know that it's better than Lipitor or better than Simvastatin, Pravastatin for somebody like this patient who's over 65 and has all these other conditions? That is the Holy Grail that EHRs dangle in front of us. That data, by the way, AstraZeneca may have that data, but the FDA would prohibit them from promoting it because of the intricacies of labeling and FDA marketing rules. But that data might very well reside in the storehouse of data accumulated by an EHR system at a hospital or in a group practice that treats many, many patients. It dawned on me a few years ago that Kaiser Permanente, or Allscripts, someone that has access to a large volume of millions of, I won't say covered lives, millions of measured lives. I guess with Kaiser Permanente it is covered lives. They would have more data in a year about a widely prescribed drug than a drug company might have based on their entire clinical development program. I think I had that revelation when the Vioxx scandal came to the headlines. The point about Vioxx was, well, it had been studied extensively by Merck and they didn't find any dangerous safety signals. And then it became apparent when millions of people started using that drug that it does slightly increase the risk of heart attack. An EHR system might be able to bubble up that safety signal easily and quickly. And I'm hoping that that's what the future holds, but we will see. So IT and big data to the rescue. I think this is an interesting sociologic commentary. So those of you who are Star Trek fans will remember, well, maybe not, most of you are not as old as Rich Altus and I, but some of you will remember from the 60s, DeForest Kelley was the doctor. He was doing also, he used fancy gizmos. He used a tricorder, which is a little bit like the wireless ultrasound machine that Siemens is about to introduce. He would give people injections right through their clothing, which seemed kind of bizarre. But he did not interface with the computer much, and that was the mindset of the 60s, although he did have a really cool readout of vital signs in sickbay. Star Trek of the 90s, late 80s and early 90s, that's the doctor in the middle, Gates McFadden, I forgot her name on the show. She was always talking to the computer. Computer do this, computer do that, computer assess this. And then in the last 10 years, the most recent I think this is the most recent Star Trek, one of the more recent, Voyager, they said, you know what, let's just forget about the human doctor. Let's just have the doctor be a hologram that looks like a human, but he's really a computer. When I practiced emergency medicine from 1986 to 1996. And there were many times, and this was before, I stopped practicing right when the web was starting. So I was running to the back room to look in textbooks pretty often. There were many times when I thought, yeah, I think I'm a good physician, but in this particular clinical case, a computer could probably do a much better job than I could figuring out best course of action, best care. And that revelation is not lost on IBM. Those of you who are familiar with Watson, and Watson beat Brad Rutter and Ken Jennings 2 years ago on Jeopardy. Watson is being programmed as a diagnostician. And that's great. That is fantastic. That is exactly what I think a lot of physicians think we need, although, of course, a lot of physicians will be threatened by that type of technological advance. Still, even Watson would have trouble with the unknown unknowns. Watson can search the 10 million journal articles that have been published in the past 20 years. But at least without the interoperability that may be elusive, Watson is not going to be able to dig into an EHR system and plumb the data, mine the data, that might answer some of the questions that could only be answered based on big data is an overused term, as people have said, but based on the information that resides within the memory systems of an EHR that manages or that aggregates many lives. Now, is it even possible? Is it realistic, or is this just a pipe dream to think that electronic health records are going to be able to begin to extract the nearly infinite amount of, be able to perform all the operations necessary to answer the nearly infinite number of questions that pop up in clinical care? I think infinity is a big number, but I think it will be possible, and I base that on my experience of watching baseball on TV. Those of you who are, and I'm not even talking about Moneyball. Moneyball was the application of some statistical principles to management of professional baseball teams to make them better. I'm talking about the extraordinary data mining that they do in baseball. A player comes up and they'll say, this guy has gotten a hit in 45 of the last 72 at-bats when there were 2 men on base and had a full count. And I'm thinking, wow, if somebody's programming the baseball archives computer to do that, surely there are really smart programmers working for the EHR companies that, maybe they are already doing it, but they should, if not, they should be doing something comparable to help physicians at the point of care. Let's see if I have time left. Okay, I have maybe 5 minutes. So meaningful use. And you guys, I don't have to tell you about meaningful use. You could probably recite these menus in your sleep. But what drew my attention when I started looking at it was this stage 3, clinical decision support for common disorders. Yeah, okay. Getting back to a slide somebody presented earlier, let's make online clinical decision support meaningful. It won't be easy, but if you really want to make these systems something that doctors view as a benefit and not a burden, help them make fast, smart, accurate decisions at the point of care. It should be more than than about capturing charges and sending information to patients. Not that patient education is not an important component of the system, but in the doctor's heart of hearts, he or she always wants to be a better diagnostician, always wants to be a better clinician. Technology should help them do that. It should not be viewed as just something they have to struggle with. Adoption, people have covered this already. I'm sure there are technophile physicians who love the EHR systems they work with, and there are technophobes or doctors resistant to change who are having a hard time adjusting. Keep in mind that in the white-collar world 40 years ago, there was an army of secretaries, or what are now called administrative assistants, who handled a lot of the busy work. And in the medical world, that was not 40 years ago, that was 4 years ago, before EHR use became prominent. One of the speakers this morning already alluded to it. What EHRs do is they take a lot of the handoffs in day-to-day clinical medicine, and they dump them back into the physician's lab. And if the systems were incredibly intuitive, if they were wired directly into the doctor's brain, that would not be a problem. But they're not. There is a human-machine interface that all of us who work with screens have to master, and it's time-consuming. So there's not, for the doctors in here, probably this will be tugging their heartstrings. For those of you who are not doctors, you probably have very little patience with physicians complaining about their plight. And I can understand that. The lowest paid physician probably makes 3 times the median income. But still, I think it's reasonable to admit or to acknowledge that being a physician is a difficult job. There's a lot of burnout. This is a Medscape survey that just became available recently. It's across all specialties. But let's look at some of the causes of burnout. Increasing computerization of practice. It doesn't have to be that way. People might have said 20 years ago, yeah, computers are hard to use, and then Apple came out with the iPod and the iPhone and the iPad, and now, even in this room, 3/4 of you are addicted to those machines, including me. I'm not being accusational. I walk around the room, and everyone's glued to these screens, right? There's something addictive about them. I go to the train to New York for work often. Most people on the Acela have their iPad and their iPhone out and are tapping away at both simultaneously. We are becoming cyborgs, for better or worse, and physicians might argue whether it's a healthy trend, but that is the trend, and it may be irreversible, so we might as well learn to live with it in a joyful way. Too many bureaucratic tasks, again, a streamlined EHR system can make that easier, not harder. Affordable Care Act, if we have 3 days, we could go into that. Inability to provide patients the quality care they need. I think a lot of what was discussed in the last few sessions today get at the potential for EHRs to begin to address that issue, that problem. Spending too many hours at work every day. Again, a lot of doctors say, a friend of mine actually, who has a lot of connections at Children's Hospital of Philadelphia, informed me that a lot of doctors take their work home at the end of the day because the EHR system that CHOP uses, I don't know if it's Epic or not, makes it so difficult for them to to chart their notes that they actually have to do it after they go home. So that is unfortunate. So there's a lot of talk about meaningful use, but really, again, I hate to be physician-centric, but I don't hate to. That's why I was asked to speak here today. A lot of the success of EHRs, at least at an emotional level, not at a billing level, will get down to how easy and how comfortable it is for doctors to use them. This is a few interfaces. I was able to pull these right off the web. Google image search. Okay, I get it. I'm sure a lot of these, once you learn it, are very easy to use. But again, they do look like the typical computer interface from the 90s. In our private lives, in our non-professional lives, most of us have moved from mouse and click and type to touch and swipe. That is a pretty remarkable change in how we interact with computers that Steve Jobs and his minions at Apple introduced, that caught on like wildfire and instantly made Apple Zoom most highest market capitalization in the world. There's a reason for that. There's something intrinsically appealing to the way we use those systems. Most EHRs, probably all EHRs, are not designed that way. I don't know if they ever will be, but think about it from your own experience. If you're in marketing, you'll probably use PowerPoint. When PowerPoint switches from one version to the next, it's a very disorienting experience. It takes a lot longer to figure out what to do to generate the kind of slide you want to generate. And you don't have a person who you just told has lung cancer sitting 5 feet away from you when you're working with PowerPoint. But that is what worst case scenario doctors have when they're navigating their way through the EHR. So usability, such a big part of every aspect of digital technology today. I get it. I get why it's difficult in the EHR world. I get it. Our company was hired by Take Care to develop online clinical decision support about 5 years ago for a few very simple common conditions. And it was a mind-numbing, brain-twisting exercise, even to come up with simple pathways for how to assess somebody with a sore throat. So I'm sure that there are many, many brilliant minds struggling with trying to make EHRs more usable. But difficult as that may be, and challenging as that may be, that I think will be one of the key pivot points to, EHRs already took off because the government pretty much made them take off. But for doctors to use them swimmingly, smoothly, affectionately, I think usability will be a key, important key. It's just a quote from some of my interviews with the doctors when I asked them about EHRs. This is a great book. Inmates Are Running the Asylum. It was written by, what's his name, Alan Cooper. That's 8 or 9 years ago. He talked about how a lot of software systems, a lot of programs we use are designed by software engineers and only minimally informed by the end user. And he compared the design of a very complex, even something like a website or a more complex platform or program, to stacking bricks. And he said a really complex website could be like 50,000 bricks. If you don't set up the bricks perfectly at the bottom, the whole thing begins to fall apart. It gets clunky, slow, it stops working, it gets awkward by the time you get up to the 49,000th brick. The analogy is, you're designing an EHR with extraordinary complexity. You launch it into whatever, oncology practice, ear, nose, and throat practice. doctors start giving you feedback. This doesn't work. This is too slow. That's not this pull-down screen we need here. If you haven't anticipated those potential necessary changes and built them into the underpinning software, it's going to be really hard to fix. And I think that's what's happening now. Somebody, Rich Altus, maybe this morning, talked about many doctors are moving to their second generation of EHRs because the practice, just after a few years of struggling, found that the first choice was too clunky, wasn't working well enough. So again, I'm a little embarrassed. This is probably very obvious to you. It's obvious to me. Usability is the key to a successful human-machine interface. There's a quote from a usability expert in the Philadelphia area, which you probably can relate to. But and even a company as wonderfully successful as Apple doesn't always get it right. Some of you might remember the Newton, which was Apple's attempt at a PDA, personal digital assistant, about 20 years ago. It failed miserably. It just didn't offer people what they were looking for. And then, they refined it, and the world changed, the technology, the hardware systems improved, and then they launched the iPad, and as we saw this morning, the iPad took off probably faster than any piece of consumer-facing technology in history. Anyway, there's no turning back. The healthcare system is bankrupting the country. We need fixes to make it more efficient, more effective. Doctors know in their heart of hearts that clear, reliable documentation is critical. They've known that for a long time. Malpractice lawyers used to tell us 20 years ago, if you didn't write it down, it didn't happen. The accountants for the healthcare systems are telling physicians, hey, we can't bill for it unless you record it, so that becomes important. And now the government is saying, hey, if you don't record it, it's not going to be part of the database, and the government is going broke. We are spending whatever it is, $2 trillion a year on Medicare and Medicaid. We think that EHRs are part of the solution. You better get on board. We have a carrot for you. We have a stick for you. Start using them, figure out how to use them, and use them not just in a perfunctory way, use them meaningfully according to the 40 different criteria that we're going to put in front of you over the next few years. But it's an idea whose time has come. If you look at this picture from, again, about 110 years ago, there were not even any charts on the beds. I think that's an interesting observation. I'm sure they kept records somehow of temperature curves, but it hadn't even risen to the point of putting the information on the patient's bed. This photo, which I saw in one of the talks earlier today, which was a little bit disconcerting, I don't know why, it's kind of like getting the exact same greeting card from two people. But this photo kind of speaks to the fact that we have reams of medical information that's not interconnected. It's not, and of course, and this is the most obvious one, many doctors can't write, so that's a potential flaw in the system. I think that says azithromycin, but I'm not sure. And so the government jumped on board, and there we have the Recovery Act and the high-tech provision. There is a paradigm shift. The winds of change are behind the sails that people in this room would put up if they were sailors. So I think if you're here, you're in the right place at the right time. The field is growing very quickly. Maybe there'll be consolidation, maybe they won't. I personally think companies that are EHR integrators at this point in time offer a valuable opportunity to the pharmaceutical industry for reasons that have come up in dialogue already. It's hard to work with the hundreds of different EHR providers in the country. So in conclusion, technology evolves really quick. Anybody know who this guy is? You know him, right? Sergey Brin, rich young guy from Stanford. So they're developing Google Glasses. And who knows if these will take off or not, but when I see this, I think about the feng shui of the EHR today in the clinical setting. I have gone as a patient and as a parent and sat with doctors who struggled with the EHR and barely looked at me or my son or my daughter. Probably all of you have had that experience. I think we'll get past that. I think technological advances will help us get past that. Again, we're 20 years into the EHR era, but we're really only 3 or 4 years into a meaningful EHR era where more and more people are using them and thinking about them, trying to improve them. So, yeah, I'm optimistic. I think the field will continue to grow and improve. My recommendation for those of you who work for EHR companies or who work for drug companies or are looking to figure out if there's a way for you to get involved helpfully and meaningfully is don't forget the physicians. they are the users of these systems. They will help determine how well they work or how well they don't work, or if they don't work, whatever. You guys figure out the grammar there. So again, it's this, the sun is setting on my talk, but I think the sun is rising on this part of the healthcare industry. Thanks for your time.
We're going to take a 10-minute break now over here.